Hello, everybody, and welcome to ReproAction's April webinar. I will introduce myself first before I pass it off to my co-host. So my name is Jessica Ensley. I use she, her pronouns. I'm the Senior Vice President of Outreach here at ReproAction, and I am based in Washington, D.C. And I'll pass it over to Andrea to introduce herself.
Hey y'all, I am Andrea Grimes. I use she, her pronouns. I am the Senior Vice President of Research at ReproAction, and I am in Austin, Texas.
Wonderful. So here is an agenda of our webinar today. I will go ahead and introduce our organization before we get into the topic overview and then panel discussion. We will have a section for some housekeeping items before we get into a Q&A that will last until 1. You can join our conversation by live posting on Blue Sky with the hashtag ReproAction or adding us at ReproAction. And if you have any questions for our panelists as we go throughout the topic interview section, please put them in the question section and we will get to them during the Q&A. So I will introduce the organization. So we are ReproAction. We lead bold action to increase access to abortion and advance reproductive justice. We are known for our left flank analysis, our willingness to hold folks on all sides accountable, whether they be allies or opposition, and our commitment to nonviolent direct action. So I will pass it over to Andrea now to get into today's topic.
Thank you, Jessica. So today we are going to be connecting the threads between the United States' ongoing maternal mortality crisis, abortion bans, and anti-abortion efforts to spread disinformation around the serious and sometimes fatal effects of abortion bans since the Dobbs ruling that ended federal protections for abortion rights in 2022. I want to start by acknowledging the real lives lost in our current landscape. Jessica, if you could advance the slide. These women's stories and circumstances are different, and yet their lives and deaths were connected by one common thread. They were either unable to access care, were given delayed treatment for life-threatening conditions, or were denied life-saving pregnancy or abortion care in the post-Dobbs United States. Jocelyn Barnica was 28 in Texas, and she died in September 2021 after providers said they could not treat her miscarriage until a fetal heartbeat was undetectable without risking legal consequences under Texas's, quote, bounty hunter abortion ban. Jennifer Alvarez Estrada Glick was 29 in Texas. She died in July 2022 after being shuffled between exurban hospital outposts and denied care throughout her complicated pregnancy, which a Texas medical examiner named as, in the New Yorker's words, quote, a factor in Yenny's death. Amber Nicole Thurman was 28 in Georgia. She died in August 2022 after being forced to travel out of state for a medication abortion and subsequently receiving fatally delayed care for complications at her local hospital. Candy Miller was 41 in Georgia. She died in November 2022 after avoiding medical treatment due to her fear of legal consequences when complications arose from a self-managed abortion. Portia Gumezi was 35 in Texas. She died in June 2023 after being denied a life-saving DNC, the performance of which ProPublica reported Texas doctors appear to fear would put them at legal risk under state law. Nevaeh Crane was 18 in Texas. She died in October 2023 after 3 separate emergency room visits for a life-threatening infection that was diagnosed too late by providers who believed they couldn't treat her until they had confirmed, quote, fetal demise. Taisha Wilkinson Sobieski in Indiana died in October 2023 after being unable to obtain life-saving care for an ectopic pregnancy while seeking emergency treatment in a post-Dobbs obstetric desert. We also know of 3 women who were identified in a Johns Hopkins study, which was published in the medical journal Chest, who died after being denied or receiving delayed treatment after the Dobbs decision, as reported by doctors specializing in pulmonary and other forms of critical care. Importantly, these are the names and faces we know, or the anonymized cases we've been made aware of, because investigations and research into the serious and sometimes fatal consequences of abortion restrictions and bans. These consequences include the closures of abortion clinics, as well as denials of care that hospitals and providers have attributed to fears of prosecution under abortion bans, and to the growing absence of reproductive health care specialists in many areas of the country. Next slide, please. Before we get into our full slide presentation, I want to take a moment to acknowledge that this is Black Maternal Health Week, founded by the Black Mamas Matter Alliance. I encourage folks to visit blackmamasmatter.org for a wealth of resources and events, including advocacy opportunities and opportunities to plug into and support the Black-led initiatives and organizations that are at the forefront of systemic change and community building. Next slide, please. So let's talk about what the maternal health landscape looks like today in the post-Dobbs United States. As we know, without federal protections for abortion rights, bans and restrictions have increased across the country. Today, 41 states have some form of abortion ban in effect, and abortion is totally banned in 12 states. The current landscape shows the US is experiencing an ongoing maternal and infant mortality crisis. Between 2018 and 2022, the US's pregnancy-related death rate was the highest among high-income countries, and while those deaths were, quote, largely preventable, disparities continue to persist and even widen. It's according to JAMA Network Open in 2025. When data was standardized across age ranges, pregnancy-related death rates between 2018 and 2022 were the highest among American Indian women, Alaska Native women, and non-Hispanic Black women, again from JAMA Network Open. In 2023, the maternal mortality rate for Black women was more than 3 times higher than for white women, 4 times higher than for Hispanic women, and nearly 5 times higher than for Asian women, according to the CDC in 2025. Restrictive abortion policies are disproportionately associated with adverse birth outcomes for Black individuals, according to a study published in BMC Health Services Research and RISE in 2021. And in abortion ban states, 4 in 10 office-based OB-GYNs report that, quote, they have personally felt constraints on their ability to provide care for miscarriages and other pregnancy-related medical emergencies since the Dobbs decision, according to Kaiser Family Foundation in 2023. Next slide, please. So abortion restrictions are connected to maternal health and mortality because they are, quote, structural determinants of health, and abortion restrictions have, quote, multi-level consequences, according to the American Journal of Public Health in a piece published last year. So what does that mean? Pregnant people must navigate the barriers of cost, geography, and uncertainty, which have consequences for both physical and mental health. Providers face legal repercussions for providing comprehensive care. Clinicians and providers in training are avoiding or leaving restrictive geographies. Clinical providers are navigating swiftly shifting legal landscapes, or they shutter entirely. Abortion bans proliferate in politically hostile geographies, compounding harm across expansive geographies such as the South. Disproportionate harm to Black, Indigenous, and people of color, young people, low-income people, disabled people, rural residents, LGBTQ people, and non-English speakers are also effects of these restrictions. Next slide. So amid the harmful effects of abortion bans on maternal health and reports of women's deaths as a result of delayed and denied care, anti-abortion leaders, organizations, and politicians have capitalized on these deaths to push an anti-abortion agenda. Next slide. Anti-abortion leaders and organizations have leaned into unscientific, unsupported claims about the, quote, dangers of medication abortion, and claimed that abortion bans do not prevent physicians from providing life-saving treatments to people with life-threatening pregnancy complications or unviable pregnancies. They have also accused members of the media, abortion advocates, and lawmakers who support abortion access of fear-mongering around criminal penalties for abortion providers and people who have abortions. Next slide. Anti-abortion organizations and leaders push disinformation in an effort to disconnect anti-abortion policies from their serious and sometimes fatal outcomes. Next slide. Such as the claim that, quote, there is no state law that denies life-saving care to pregnant women, which Live Action tweeted on X in December 2024. The claim that, quote, pro-abortion lies caused the deaths of Amber Nicole Thurman and Candy Miller, which was posted by SBA Pro-Life America on X last September. The claim that, quote, unsupervised abortions using medication are, quote, risky, according to the American Association of Pro-Life Obstetrician and Gynecologist CEO Christina Francis in an Atlanta Journal-Constitution op-ed. The claim that abortion care is not necessary to treat pregnancy complications, another claim from Christina Francis and the then Americans United for Life president Catherine Glenn Foster in Newsweek in 2022. And multiple claims on multiple fronts that abortion restrictions do not increase maternal mortality. We've heard this from the Charlotte Lozier Institute, Senior Associate Scholar Michael New, from Charlotte Lozier Institute's Ingrid Scott, and from APLOG CEO Christina Francis in Senate Help Committee testimony, among many other occasions. Next slide, please. Anti-abortion leaders, organizations, and politicians also back policies that compound harm, including state and federal cuts to accountability, to data collection, and research programs focused on maternal and infant health. Next slide. Georgia, for example, dismissed its entire maternal mortality review committee after committee findings connecting women's deaths to state abortion restrictions were shared with ProPublica. Texas's maternal mortality committee has declined to review post-Dobbs deaths. Texas has also revamped the makeup of its maternal mortality committee to include an anti-abortion physician. And the Trump administration has cut the entire pregnancy risk assessment monitoring system team and most of the CDC's Division of Reproductive Health. In conclusion, it is clear that we need more, not less, research and data on maternal mortality writ large, and especially as the United States' ongoing maternal and infant health crisis intersects with the consequences of abortion bans and restrictions. This is especially urgent as we expect abortion opponents to continue to ramp up misinformation and disinformation around the post-Dobbs reproductive health landscape. Now we are going to hear from two experts who can help us unpack the data we have and learn how advocates can get involved in improving health outcomes and countering anti-abortion misinformation and disinformation. So I am pleased to introduce you all to Sarah K. Redd, PhD and MSPH in Georgia. Sarah is an assistant professor in the Department of Behavioral, Social, and Health Education Sciences and the Director of Research Translation with the Center for Reproductive Health Research in the Southeast, RISE, at the Rollins School of Public Health at Emory University. Trained in health policy, health services research, and social science, Dr. Redd is an interdisciplinary scholar of sexual and reproductive health in the United States. More specifically, Dr. Redd studies domestic, sexual, and reproductive health policy, structural determinants of access to and use of comprehensive SRH care, and downstream health outcomes and multi-level SRH stigma and disinformation. Informed by the reproductive justice framework, Dr. Redd examines and highlights how socio-political systems and structures enforce or ameliorate inequities in SRH access and outcomes, paying special attention to those living in the South. Additionally, Dr. Rudd is privileged to collaborate closely with several local and national reproductive health rights and justice organizations to support and conduct community-led and community-driven SRH research. Welcome, Sarah.
Thank you so much for having me. I'm so happy to be here.
Fabulous. So your expertise is in structural determinants of access to and use of comprehensive SRH care and downstream health outcomes. Can you translate that for our general audience and talk a little bit about what drew you to your field?
Absolutely. And I appreciate that question because that's a great example of some really researchy jargon that isn't always easy to tease apart. So what I really mean by like structural determinants of access to care is essentially what are the underlying systems or factors that shape individuals' experiences and opportunities that they have no control over. So what are the things that are outside of someone's control? So it could be the state policies that they live in, of the states that they live in. It could be, how well resourced the health service system is in the geographic location where they live. How are these things that are outside someone's control, how do they directly affect their ability to access healthcare, to use healthcare? Because we know that just because someone theoretically has access to care through insurance coverage per se, that doesn't always mean that they can actually easily use that care. And ultimately, how does healthcare access affect their health outcomes? So as is, I kind of mentioned in my extremely long and wordy bio, state policy is one great example of a factor that is totally outside someone's individual control that directly affects their ability to access healthcare, use healthcare, and which ultimately affects their downstream health outcomes. That could look like, based on this conversation, of course, most relevant is laws restricting access to abortion care. That's something that is, often enacted at the state level, that directly affects someone's ability to either access abortion care or not, and which we've seen on Andrea, you did such a great job providing an overview of how these are directly related to health. And so those are kind of the things that I'm really interested in, kind of how these structural system level factors affect us individuals, us individual people who are having to live under those constraints. And I really appreciate the question about kind of what drew me to the field. I think it's a little bit of a couple of different things. I'm a Georgia native, born and raised. And I had kind of some family connections early on related to reproductive health. My mom had an ectopic pregnancy in the 80s here in Georgia and almost didn't make it because of her healthcare providers weren't listening to her experiences. Ultimately, she did receive care for that ectopic pregnancy, but that was a story that I heard a lot growing up. And also growing up in Georgia, a state where we had, state mandated abstinence-based sex education. For example, my sex ed teacher in middle school said that she had her kids via immaculate conception. So, that was an interesting thing to experience as a young person who might be able to become pregnant. But also living in Atlanta, we have a large local presence of abortion clinics that many of my family and friends were involved in. And also growing up in Atlanta, which is a home of so many social justice movements, that inherently kind of like directed me towards how power structures can really harm and inequitably affect people, and just kind of the need for this work, these groundswells of activity to really keep communities healthy and keep people healthy. So
thank you. So in your work, you have identified really clear connections between restrictive abortion policy and adverse birth and maternal health outcomes, among other consequences. Can you explain how these policies and outcomes are related? How can we tell that one follows the other?
This is another really great question. I think there are a few different ways to kind of think about the relationship between restrictive abortion policies and like abortion bans, which we are, so much of the country is under now, and adverse maternal and infant health outcomes. First, we know that pregnancy and childbirth is much more dangerous than legal induced abortion. There's a study that is often cited that showed the risk of, I think it's from 2012, but showed that the risk of death associated with childbirth is 14 times higher than the risk of death associated with legal induced abortion. So by nature of if someone is living in an environment where they can no longer access abortion care, if someone is carrying a pregnancy to term and going through childbirth, the option of abortion is no longer available to them simply because they are carrying the pregnancy to term and going through childbirth. They're thus more likely to experience pregnancy complications or poor birth outcomes just by going through this process. And again, we have already seen this happening. We already know this is happening. Again, you did a great job of highlighting even just some of the, community members who we've lost due to these abortion bans to, from my home state here in Georgia. And again, as you mentioned, this is just the people that we know about. And these are just the, most egregious outcomes of actual death. But we also know that there are huge implications for abortion bans for pregnancy complications. And unfortunately, especially in states with bans where there are some exceptions for people's, the life or health of a pregnant person, that's just made it so much more complicated for the clinicians who are actually providing care, for them to actually be able to deliver the care that they know can save someone's life. And it's just put the health of people who are going through pregnancy at such an increased risk. But additionally, another factor that kind of links these two things is that people who are, well, really living in the current healthcare infrastructure in the United States broadly is pretty broken. And unfortunately, in some states, in some areas in particular, the healthcare infrastructure is extremely strained. So when you have more people who are forced to continue unwanted pregnancies or are forced to continue pregnancies that they may have otherwise pursued an abortion, they're likely going to be facing additional barriers to accessing healthcare. And that could be, lack of insurance coverage or lack of, solid insurance coverage. So they could be underinsured, shortages of primary care and obstetric providers, not being able to access care that's close to home, that's affordable, that is respectful care. And also, unfortunately, a lot of the states that have these significant restrictions on access to abortion care tend to also have very few policies, if any policies, that actually support families, that support people and families, like paid family leave, paid medical leave, Medicaid expansion, requiring, accurate sex education in schools. So facing those kind of structural barriers to care and living in these restrictive environments increases the risk for poor outcomes. And the last piece that I think is really important, and is pretty simple, it's related to the other two, is that we know there's a really rich evidence base that stress increases the risk for poor pregnancy outcomes. And when you kind of consider not only the sociopolitical context of the United States that we are currently living through, but also the huge barriers to care that people in large areas of the country are not able to access, or are experiencing, it is an inherently really stressful environment. And so all of that together are really kind of like how we know that these restrictive abortion bans can directly lead to poor birth outcomes and poor maternal health outcomes.
Thank you for that synthesis. So you also study mis and disinformation around sexual and reproductive health, which we have seen have an increasing impact on reproductive health policy and care provision post-Dobbs. What do you see as some of the most concerning or impactful effects of this mis and disinformation, and who is most affected by it?
I think that this is such a great question, and there's so many different directions that I can go in with it. One of the things that I think is incredibly concerning is just all of the different ways and forms and kind of flavors that mis and disinformation can travel through. You know, it can spread through social media. Lord knows, I see so much mis and disinformation happening on social media. It can, through which then can be transmitted through like casual conversations between friends. Oh, I saw this thing on Instagram last week. But and I think you kind of showed in some of the earlier slides, it can also be transmitted through these kind of quote unquote research institutes, these anti-abortion research institutes that are pushing out bad science that then people in the legal and political system are kind of pouncing on, and then using that to create state policy or to advance certain lawsuits that are trying to restrict access to care. And so it's just so concerning to me, all of the different ways that misinformation can make its way into our communities. Definitely my biggest concern is those who are most affected, and that's us, that's individuals, that's people who are just normal folks who are trying to live their lives and make decisions about their reproductive lives, and either directly encountering misinformation through like social media, or talking with people in communities, or hearing a news article, or by just living in environments where access to care is restricted based on mis and disinformation. All of that affects individuals, and it just sucks to know that like people are interacting with mis and disinformation that might then be changing their behavior in one way or another, and ultimately it's really being kind of weaponized to control people's ability to live their full reproductive lives. So those are just a couple of concerns that I have.
Absolutely. It is really scary out there, and the impact is real. I am going to skip your fourth question and save it for the Q&A later, and
Sure.
turn it over to Jessica, so we can get to our next panelist. Thank you, Sarah.
Great. Thank you, Andrea and Sarah. It's my pleasure to introduce our second panelist today, Dr. Reagan McDonald Mosley, MD, MPH. Dr. Reagan McDonald Mosley is the CEO of Power to Decide, a private, nonpartisan, nonprofit organization that works to ensure all people have the power to decide if, when, and under what circumstances to get pregnant and have a child. She also serves as the co-director of Dr. Shalon's Maternal Action Project, a nonprofit dedicated to supporting Black people through pregnancy and childbirth to close the maternal morbidity and mortality gap. Previously, Reagan served as the Chief Medical Officer of Planned Parenthood Federation of America and interim president and CEO of Planned Parenthood of Maryland. Reagan has participated in several international public health projects in Latin America and Sub-Saharan Africa. She is a graduate fellow of the Physicians for Reproductive Health Leadership and Training Academy. Reagan served on the board of directors for Healthcare Access Maryland and is an active member of her community. She has earned her bachelor's degree in African Studies with the highest honors from the University of North Carolina at Chapel Hill and her medical degree from the University of Pennsylvania School of Medicine. She completed her postdoctoral training in obstetrics and gynecology at the New York University Medical Center, and she has also completed a specialized fellowship in family planning at Johns Hopkins University School of Medicine, during which she obtained her MPH from the Bloomberg School of Public Health. Reagan, thank you so much for joining us here today.
Thank you for having me.
My first question for you is, you've built quite a career combating negative reproductive health outcomes and maternal mortality, both in the United States and abroad, via abortion bans and the consequences for people living in geographies with limited or no access to comprehensive reproductive health care. So, can you give us an overview of what that journey has involved for you?
Yeah, so when I was a senior in college, I had the opportunity to spend the fall semester at the Kilimanjaro Christian Medical Center in Moshi, Tanzania, studying the causes of maternal mortality. And this was back in the late 1990s, and I had sort of hypothesized that hypertensive disease of pregnancy or hemorrhage or HIV would sort of be the leading causes of death, and I was completely wrong. Complications of unsafe abortion were the leading cause of death. And while I did spend most of my time over that semester in the medical records department poring over dusty, mite-ridden hospital records, I actually saw and witnessed firsthand a number of women come into the hospital dying or at death's door from complications of unsafe abortion. And this was, as you can imagine, a transformative experience for me as a young person, to see this firsthand and sort of put me on this trajectory to try to use my skills and my voice to remove the possibility of anyone suffering this outcome. And frankly, I never imagined that we'd be fighting so hard here in the United States for basic reproductive rights. I did a lot of work in sub-Saharan Africa, a bit of work in El Salvador, and then made a strong pivot to doing more work domestically during my fellowship in family planning and thereafter, where I was working at Johns Hopkins and locally at Planned Parenthood of Maryland, and faced with the very real barriers that people who grew up like me, people in my own community where I was living and raising my kids, the barriers they had to high quality comprehensive reproductive health services right here in the United States. So I did serve in various leadership roles at Planned Parenthood of Maryland and then Planned Parenthood Federation of America, and then made my way to Power to Decide 4 years ago, which has been an incredible opportunity to work in the liminal space, right? Like before people even get to the brick and mortar health centers or to a health provider, the minute that they have unprotected sex and freak out and are concerned about what to do, or take a pregnancy test at home, or have questions about their birth control options, we're meeting them there in the digital space with our pop culture integrations and on social media, where people, especially young people, are spending a ton of time. And that work, of course, has gotten harder due to not only the bans and restrictions on abortion, but also the pervasive misinformation and deliberate propagation of disinformation about sexual and reproductive health topics in many of those spaces, as we've been discussing.
Thank you so much for walking us through that. And I can imagine how you start off your senior year must have been incredibly transformative. So thank you for that. So you mentioned, you've made a little bit more of a switch into focusing more domestically, which leads me to my next question. What are the major barriers of comprehensive reproductive care? You touched on this a bit. I'm including pregnancy and pre and postnatal care, abortion care, contraception, or fertility care in the United States now that we are in this post-Dobbs era.
Listen, we could spend the entire hour on this one thing, but I'll say, like, there are major barriers, right? Like, we are dealing with a completely dysfunctional healthcare system overall. That's really only working for the uber wealthy and not even that great for them. It's fractured, it's disjointed, it's very hard to navigate. And so then you take that and you overlay on systems of oppression impacting people who face the most barriers to information and quality care. And then on top of that, you overlay a policy and regulatory environment that's openly hostile to sexual and reproductive health in over half of the country, and really everywhere to some extent. And so this causes delays in care, people unable to get care, We know that 19 million US women of reproductive age live in contraceptive deserts, which is areas where they don't have reasonable access to the full range of contraceptive methods. And around 1.2 million of those women live in a county without a single health center offering the full range of methods. Additionally, more than 2.3 million women live in maternity care deserts where there are no hospitals or other providers providing obstetric care. And we know that this number is growing, right? Because as has been pointed out, many health centers are closing in this landscape, and many providers are fleeing these states with bans and restrictions because they don't want to have to practice medicine that's out of the standard of care. There's no procedural abortion in large swaths of the country, not to mention the difficulty of navigating these intersecting challenges of being someone with a lower income and having to navigate childcare or lack of funds for copays or travel. So access to reproductive and sexual health care was broken and out of reach for many before Dobbs, and now these barriers are increasing for everyone.
Absolutely. Thank you for giving us an overview. I know we absolutely could talk about that for the full hour. And since we know from some of the examples that Andrea provided earlier and from our discussion today, that these barriers that folks are facing have a disproportionate impact on Black women and others who have intersecting or marginalized identities. Can you speak a bit more on those impact and implications of where we are now?
Yeah. This is such an important question, and thank you for lifting up that it's Black Maternal Health Week. But like, really, right? Like, reimagine all of those sort of the framing of how broken our healthcare system is. What if it was like Black Maternal Health Year or decade, right? And we like focused on fixing the healthcare systems so that all of the barriers were removed to improve this um, terrible outcome. Then not only would the health improve for Black women, but for all women. And not only would health improve for all women or people capable of reproduction, but it would improve for everyone. So sorry, I'm just like so frustrated that we like allow ourselves to sort of just talk about these issues when we actually know how to fix them and recognize that it would actually improve healthcare for everyone in our entire country. But we know that restrictions on abortion and contraception and maternity care further deepen these inequities and worsen health outcomes, putting lives at risk and stripping communities of autonomy, dignity, and essential healthcare services. We know, as has been discussed, that Black women face the largest barriers to care, and the outcomes of that are a growing and worsening maternal health crisis for Black women specifically. All of the things that we've discussed, right? Like the brokenness of our healthcare systems, the systems of oppression, they impact Black women specifically and uniquely in ways that mean that the Black maternal health crisis is increasing. And we know that Black women are more likely to live in states with bans and restrictions. We know that they're more likely to disproportionately be impacted by these abysmal regulations. And so there's already terrible maternal health crisis in the Black community, and it's worsening every day that these unjust laws persist.
Absolutely. And how have you seen the effects on of the anti-abortion, anti-contraceptive, and broader anti-science policies play out in communities where you serve and advocate for? What impacts have you seen abortion stigma and mis and disinformation have on those communities? And how do you shift your work to address that?
Yeah. I mean, I really think that abortion stigma is the thing that's undergirding all of these unjust restrictions and regulations, right? Because it's because people think or are being told to think that like abortion needs to be more regulated, that they're like, oh, okay, we'll tolerate this, these impacts on abortion care that aren't applied to other types of health care. So it is critically important that we address stigma in order to envision a more optimal future for reproductive dignity and reproductive well-being, where abortion is healthcare, period, and stop. You know, that you can get abortion in the same place that you go to get your regular family practice care, right? And it's not sort of stigmatized and siloed. And the pervasive misinformation and perpetuation of deliberate disinformation is having real world consequences. People are scared to use birth control. This is not just theoretical. We are seeing this where people are using birth control to a lesser degree. We recently did a survey, the Your Health survey, of young people that showed that nearly 1 in 5 people believe that they should take a break from birth control pills every few years. And 61% weren't sure if that was true or not. And 23% of people said that they thought that menstrual tracking apps were a highly effective way to prevent pregnancy. So there's a ton of confusion about contraception, and this is being perpetuated by the amount of mis and disinformation that people are encountering in the news and in social media and in other places. And these gaps in knowledge highlight the urgent need for accurate, accessible, and trusted reproductive health information. And that's part of the work that we do at Power to Decide, where we're working to combat misinformation head on by delivering critical health information through our Ask Dr. Reagan series, for example, on our bedside or social media channels, where we provide candid, judgment-free sexual health information that finds people where they're already spending a lot of time. We also have bedsider.org, which is our digital resource that offers medically accurate, relevant, and resonant information on all aspects of reproductive well-being, including sex, sexual health, healthy relationships, and birth control. And we're also working through Abortion Finder to provide clear, verified information about abortion access with extensive user experience research to make sure that it's usable and clear.
That's wonderful. As you've mentioned, there's so many barriers that people seeking abortion care or comprehensive sexual health care are facing. And so it's great to have resources like those in order to help people navigate any sort of questions or help that they may need. Thank you so much for sharing your expertise with us.
My pleasure. Thank you for having me.
Wonderful. And if people have questions for Sarah or Reagan, please enter them in the questions section. I'm going to go to some housekeeping items before we get to the Q&A. So you can plug into ReproAction campaigns at reproaction.org and follow us on social media at ReproAction on every platform. And then save the date for our next webinar, which is What is Abortion Abolition and Why Does It Matter? That will take place Tuesday, May 27th at noon Eastern Standard Time. So I am going to get into the Q&A section, and I will kick it over to my co-host, Andrea, to ask the first question.
Thanks, Jessica. So this is the question that I have for both Sarah and Reagan. We've covered a lot of barriers and implications and harms and impacts. But I'm curious to hear, sort of turn to a more positive note. How have you both seen folks in your communities and advocates working on the ground respond and adapt creatively and resiliently to the challenges that we are facing around access and to the growing maternal and infant mortality crisis in this country?
I can jump in. I love this question because I think it's really important to talk about what is working or all of the work that is being done. Speaking kind of from the Southern lens, from my lens here in Georgia, what we have, like, not while we are living and existing in these incredibly difficult, oppressive environments, not only in terms of abortion bans, but also, as Dr. Reagan was mentioning, these like incredible issues facing our maternal health service delivery system. But what we also have, and what we have always had, is this really rich, dedicated, passionate movement of visionaries. And that's people, it's organizations, it's advocates, it's collective groups who are working to advance and to protect reproductive health rights and justice. In Atlanta in particular, we are really a hotbed of reproductive justice organizations. And we have this incredible close-knit web of groups, advocates, community-based clinics, independent clinics, direct aid organizations who are working
collectively and simultaneously to really adapt to these constantly changing environments and incredibly and increasingly restrictive environments. So here in Georgia, we have even though we have, this restrictive early abortion ban, it's, a 6-week ban roughly, these groups have been pivoting and creating new solutions to stay open and to continue providing abortion care to Southerners and providing the safety net for Southerners, like through some of the direct aid organizations that we have, our local abortion fund. And so, we just have this incredibly rich network of folks who are just doggedly working to try to keep this place, just to improve reproductive health rates and justice in this region. And one more concrete example of this is, so in Georgia, there's one of my very dear community organizations, Amplified Georgia Collaborative, has been leading an effort to get a bill introduced in the Georgia legislature called the Reproductive Freedom Act. And after many years of working behind the scenes, they finally, I think in 2023 was the first year that we got it introduced. And this is a bill that seeks to reverse all of Georgia's restrictive abortion policies and actually enshrine protections for people's reproductive freedom in Georgia. As you can imagine, it's not, the most, there's challenges to having that bill move forward, but that's just another example of like how people are remaining rooted in our, values of the beliefs of, what a liberated future could look like, and not letting these oppressive forces kill our spirits. So I'll stop there.
Thank you so much. I want to expand that to see if Reagan would like to add anything onto that.
Yeah, thank you for like pivoting us to hope, given all of the crazy things we were discussing. But, what gives me hope is seeing folks in community-based organizations and on the ground deciding like, we're not going to wait for the healthcare system and policymakers to save us. Like, we're going to do this work because we have to, because we're Black women and we have to protect ourselves and our children, right? So for example, I was blessed to be able to speak at the Maryland Black Perinatal Health and Reproductive Justice Summit last year that was hosted by A Force, Tanae Harris, and the Bloom Collective. And it was just an amazing and uplifting convening with amazing speakers who talked about things from birthing justice to, building the bridge and strategies for advancing Black maternal health policy. And at the end, they worked on designing and writing novel policy to address Black maternal health disparities in Maryland. So the idea of sort of participatory policy making was just so inspiring. And that is what's giving me hope, is like we're recognizing that our systems are broken and that our leaders are not doing what they're supposed to do, and we're taking things in our own hands.
Wonderful. Thank you both. That leads me into the next question, which is for folks who are pregnant or plan to become pregnant, how can they protect themselves, protect their own reproductive health care, especially when facing systemic challenges and barriers to care? And that's both for Sarah, Reagan, who would like to take that.
So, I mean, I'll start by saying it like shouldn't be on the folks who are facing inequities to protect themselves. That being said, we recognize, as I just said, that like leadership is broken, the healthcare system is broken. So a couple of things that folks can consider doing is just making sure that they advocate for themselves. Like, we are trained to be deferential to healthcare providers. I have seen it. I've been on both sides of this, and I've seen it be a very dysfunctional paradigm. And so recognize that like just because someone's in a white coat or has like fancy letters behind their name, they're not the boss of you, and they are not the expert of you, your life, and your body. And so if you're saying like, this is what I'm experiencing, this is what's happening, and they're not listening, you can feel free to push back. And if you feel like you're still not getting the answers that you need, and the respect that you need, you can look elsewhere for care, which I know is not an easy thing to ask given how hard it is to get in to get healthcare appointments, to find a good provider. But just know, if the provider in front of you feel like is not listening to you or giving you the time and space that you need or taking your concerns seriously, you can get another opinion. Another thing I often recommend is, because it's a very stressful thing to get healthcare and interacting with the healthcare system, is to write down your questions and concerns to make sure that you don't forget. And if possible, bring someone with you, because having another set of ears and someone to advocate for you can be critically helpful. And if you're having a procedure, or certainly in the birthing setting, having a doula or just, a trusted person that can advocate for you is critically important.
That is such a good point, and it seems so simple, especially the first section. But for instance, I'll give a personal example. My very first OBGYN, I was asking for a form of contraception that she refused to give me. And so I just sort of accepted that and was using a form that I didn't particularly like until college, in which I had a discussion in my women and gender classes, and everyone turned around and was like, you can go to a different doctor. And I was lucky enough to like have healthcare, have insurance, and then have options for other OBGYNs to go to. So I was able to do that. But that was just something that genuinely did not occur to me from the ages of like 16 to 19. So I think that's really important. Just like, you can always ask questions. You are the final arbiter of like what happens to your body. And so to be curious about that whenever possible.
Yeah, and unfortunately, that is not a unique experience, and this has been well documented. Dr. Anu Gomez published a research study that I was able to participate in last year on estimates of use of preferred contraceptive methods in the U.S., and found that I believe about 25% of current and prospective contraceptive users reported that they wanted to use something else, but for some reason, right, because a provider told them they couldn't, or they couldn't pay for it, or whatever systematic reasons, they weren't able to use their preferred method. So we have to do a better job, right? Like, there is no perfect contraceptive method, and oftentimes people have to try different ones until they find the one that works for them, but people should have access to all of them.
Absolutely. Yeah. Thank you. And thank you for sharing your expertise on that. Sarah, did you have anything that you would like to add on to that of what folks can do to protect their own reproductive health care, or I can move on to the next question?
I think Dr. Reagan did a fantastic job of answering that question. So feel free to move on to the next one.
Cool. Well, my next one is directed towards you, Sarah, then. How do cuts like programs to PRAM, or the dismantling of maternal mortality review committees, maternal health committees, affect your ability to do your work, or affect, the research field in general? And what do you expect the impacts of deprioritizing investment in data collection and research to be moving forward?
This is such a great question, and one I'm thinking about all the time. It's honestly a little challenging to even begin. And I should kind of back up and say, like, I am one of the reasons why I ended up in research is I'm just like a huge nerd, and so some of these like PRAMS, for example, the Pregnancy Risk Assessment Monitoring System, is a survey that's been conducted by the CDC and in partnership with state health departments for decades. And for example, I used PRAMS in my master's thesis. And so for this, kind of going deeper into PRAMS, that has given us a perspective into the experiences of pregnant folks, and both like experiences before, during, and after pregnancy. So it gives kind of this window into people's experiences on a more systematic level. And so with the loss of things like prams, we're just continuing to learn every day, truly. What are the other things that we're losing? We've even, with the cuts to the Division of Reproductive Health at CDC, we've lost the group who have been updating contraceptive safety guidelines for clinicians, right? So it's not even just data collection efforts and kind of sort of surveillance, but which is kind of creepy if you kind of think about it that way. But we're losing such key resources for our healthcare system. And in terms of research and what that means for the work that I do, I mean, I tend to use in my kind of like quantitative, really dorky work. I use these large data sets where we're, that are often collected by the federal government, including even, birth records, right? That contain information on, all birth certificates, and birth, vital birth records. So what were the outcomes for the infant? What were the outcomes for the pregnant person? There's so much information that we get about the health of our population, and even, kind of smaller within different regions, within different states, within, different kind of regions of the country. There's so much information that we're going to be losing. And, I think it remains to be seen how much more they're continuing to cut. I tend to be in a pretty cynical space these days, so I don't have I'm in a pretty cynical space. But it's just really scary. It's really scary. I think there's a lot of unknowns. And I think, of course, the larger concern is just like the dismantling of the public health infrastructure of our country. And ultimately, for me, what brings me the most, really deep grief is seeing how this is going to affect the health of our population, way beyond the research. How is this going to affect the health of our communities?
Yeah, thank you for sharing that. And you are not alone in this sort of, the struggle to avoid cynicism, for sure. So we have a question that sort of leads into that. I don't know if you can answer that, or if Reagan can answer that. And the question is, does the trend of infant mortality sort of track similarly to that of maternal mortality?
I can just speak to that from a data perspective. It is not, yes, is the short answer. And interestingly enough, one of the reasons why there is often kind of a lag on maternal mortality data is because maternal mortality is comparatively to some other health outcomes pretty rare. One is too many, for sure, but maternal mortality itself is quite a rare outcome. Unfortunately, getting less rare. Unfortunately, doesn't even cover it. But infant mortality is more common, and that is something that we've started to see direct research kind of exploring what are the effects of these specific abortion bans on maternal mortality. There was a paper that was looking at Texas's 6-week ban that they had implemented in 2021 prior to the Dobbs decision, in which they implemented their total ban. But what that research paper found was that 6-week ban led to a 13% increase in infant mortality and a 23% increase in infant deaths due to congenital anomalies. So in terms of, the relationship between abortion bans and infant mortality, it's directly the same relationship as with maternal mortality.
Yeah, I mean, that was so well said. I'll just add that like maternal mortality and infant mortality are related but distinct indicators of population health. And just a sign of like, how healthy the healthcare system is, right? And as was stated, we know based on a lot of extensive research that places that have a lot of bans and restrictions for abortion have higher rates of maternal mortality. And now, as Sarah just stated, the research is coming out that there's a link between bans and restrictions and infant mortality as well.
Got it. Thank you both. We're Getting close to time, so we have time for one final question. We've sort of touched on this throughout, but it is, how can we navigate the dynamic of all the dis and misinformation occurring online and through bad actors such as the anti-abortion movement leaders and groups, and fact-based information that we can hopefully get from healthcare providers. So I want to open that up in our last minute or so.
You can go ahead, Sarah.
This is a great question, and I think honestly, it can be challenging because a lot of times we don't even recognize when we're interacting with or receiving mis and disinformation. But what I would say is that there are so many good organizations who are directly trying to combat mis and disinformation. There's so many incredible orgs, and like either through a concentrated effort, but also just by doing the work that they're doing, and so it's, I don't know how helpful this is, but trying to get stay grounded in the organizations that are combating mis and disinformation and are actually putting out actually medically sound evidence-based information is kind of where I would start. I mean, certainly Repro Action is like an incredible example, and there are so many other great organizations who are doing this kind of work.
Absolutely. Oh, sorry.
Yeah, I'll just add that like there's a ton of researchers studying like how best to combat mis and disinformation, and so I think we'll know more, in a couple of years. But in the meantime, I encourage folks to like use evidence to combat blatant disinformation where they can, and to elevate resources like Bedsider, Abortion Finder, the hashtag Ask Dr. Reagan series on our social media platforms, as well as other providers and sex educators and really smart people who are elevating, things that are true and honest and real, as resources as well. And thank you so much for the opportunity to be a part of this discussion today.
Absolutely. Thank you both so much, to Reagan and Sarah, for taking the time out of their busy schedules to educate us. And thank you to my co-host, Andrea, for putting this all together. Yeah, thank you again so much, everybody, for joining. I hope you have a great rest of your day, and take care, everyone. Bye.